Good afternoon. Today we have Dr. Raphael Penanuri. Dr. Penanuri is a board-certified addictionologist with over 40 years of experience. He's helped thousands of people in Southern California, and specifically his office is in Newport Beach. But he provides treatment both virtually through telehealth and also in person at his office. Dr. Penanuri was one of our former medical directors as a board certified addictionologist, helping a lot of our patients. He currently consults with our companies, and he's a great resource to have for our staff and for our clients. So tell you a little bit about myself. I'm an executive in the behavioral health space. I've been owning and operating both behavioral health facilities, mental health, and substance use treatment, addiction treatment for over the past 10 years. And we're really excited today to focus our conversation with Dr. Penanuri on what's called MAT, which is medication-assisted treatment. It's something that we provide at our facilities, and it's something that is promoted both federally and by the state of California. So we want to get a little bit more into that as far as what are some of the MAT protocols, what are the different questions related to MAT. So without further ado, I'd like to just have Dr. P introduce himself. We could learn a little bit more about him, and then we can get into the questions.
Hello, Tom. I'm glad to be here with you. It's a pleasure to see you again.
Yes, thanks for
It's been several months since we last saw you, but it's good to be here again. I've been in medicine. I've been practicing medicine for the past 40 years. I specialize in addiction medicine. I have my own office in Newport Beach. And I go to a few facilities. I also practice over at the Hoag Hospital and their detox center. So I have lots of experience in addiction medicine, and I've been treating a lot of patients. And it's a pleasure seeing these patients get better.
Right.
And it's nice to have the availability of certain medications nowadays that we didn't have in the past. But as far as addiction, we treat all kinds of different addictions. It could be alcohol, it could be benzodiazepines, it could be opioids. What we're here today is mainly for the discussion of opiates, and also to discuss MAT treatment. MAT treatment is basically a medically assisted treatment for opioid use disorder, which we're seeing plenty of nowadays, which involves prescription medications for pain control, from hydrocodone to OxyContin. And then those are for pain medications that people do get addicted to and subsequently start abusing them. And but the problem now is that there's always new medications coming on board, or new drugs coming on board that are much more potent, more stronger, such as fentanyl, which kind of overtook the heroin. Heroin used to be the kingpin, but now It's fentanyl. And fentanyl is a very deadly type of substance abuse or drug. And it's very potent, and it's a great cause of overdosing and death.
right.
But fortunately, we do have medications such as Suboxone, or the generic for that is buprenorphine, which we use quite consistently. It's a medication that allows us to treat people who have fentanyl or heroin addiction or generalized opiate addiction. But that's what we're going to discuss, and
Yes,
we'll
get into more details.
Yeah,
And I thank you for the introduction. And one thing to know about Dr. Penanuri is that he himself raised his family locally. So he's from Newport area, Southern California, raised 3 lovely children, and your wife was also a physician before
she's a pathologist. Yeah.
Right.
Yeah.
And so that, it runs in the family. So, I mean, you've seen, and based on your experience, you kind of have what I would consider the trifecta of experience. So you have experience as a physician yourself, treating patients in your clinic. And then you also have experience as a medical director of residential treatment centers, which in Southern California, that's a primary model of treatment is through residential treatment, both at the residential detox and also residential treatment. Usually over the course of a month, people go to these types of facilities before going to outpatient care. And then in addition to that, you have experience at Hoag Detox, which is a little bit more of a hospital-based detoxification for more of an acute care setting. So you have treated, the individual, and you've also treated them at different levels with MAT and also with other methodologies at the acute and subacute level. So I think that's important because not everyone has that breadth of experience, and maybe at some point we go a little bit more into how you see those different settings for different types of patients and what's the best fit for them. But before we get into any of that, I think there's certain questions that our program director has put together, and he works with medical director and with our consultants to put the best program together and utilize that as training for our staff and also for best practices for the patient. So we'll get into some of those questions. Sure. First, let's start with what is MAT and what are the benefits? What is MAT and what are the benefits? What is MAT and what benefits does it provide the patient?
Yeah, MAT, as we mentioned before, is medically assisted treatment. And medically assisted treatment, that's regarding for opioid use disorder. Excuse me.
We could start at that question. We could do the question again.
Yeah.
Do that question again.
Are you rolling?
Yeah, we're rolling.
Okay.
So when we've got doctors, they have to.
Yeah.
Doctors can't put their phone on silent. They have to be.
Yeah.
They're on call at all times. So.
Sorry about that.
No, that's okay.
Spam call.
Okay, so we'll go ahead and have you ask that question again to get there. And I'm sorry, my computer kind of sleeps sometimes, and that's
Yeah.
So I'll keep an eye on it. Okay.
All right.
So let's go ahead and take this question one more time.
So Dr. Pedinuri, what is MAT and what are the benefits it provides to the patient?
Okay. MAT is medically assisted treatment, and that's referring to medications for opioid use disorder.
Okay.
And the benefits are basically it reduces relapse from going back to drugs again, such as opioids, heroin, fentanyl, and it reduces overdosing. There's a lot of overdose situations in the United States, a lot of deaths. So basically, the biggest benefit it has reduced the death rate and overdose rate that we have in the United States.
Right. And so it's a method of essentially harm reduction and mitigating the impacts of these opioids and the consequence, which is overdose. So as you've seen, as the utilization of MAT has increased, have you seen a correlated decrease in deaths and also overdoses, or at least overdoses?
Yeah. Well, MAT has been extremely helpful in the reduction of overdoses and death in people who use opioids.
Right.
And the problem is that as we progress, we get newer drugs that come in, and these drugs are stronger and more potent and more likelihood of causing overdose and death.
Right.
So we've been consistently battling these over the years, and we've been using MAT to try to stop that, at least slow it down as much as we can. Okay. And that's been very helpful. But at the same time that we're trying to slow it down, there's always new productions and stronger medications. So it's a constant battle. But in the past years, from 2015 through 2020, 2022, the overdose and death rate have consistently have been rising because of these new drugs. But with the help of this MAT, we've been able to fight it. Now the overdose and death rate have been declining in the past 2 years, 24 and 25.
Right. In regards to the medications that we can actually, counteract.
Yeah.
Because as you said, there's always new stuff coming out.
Yeah.
And that, in the future, I'm sure they'll have medications for that. But currently, it's in medicine, you're always battling, these manufacturing companies that are creating, new pharmaceuticals versus what you have the antidote for, essentially. So, so next question is, why is MAT considered the gold standard for treating opioid addiction?
It's considered the gold standard because it is very helpful. It works. There's more evidence based that it actually works. But the reason it's actually called the gold standard is that there's no other way or method that comes close to MAT treatment in preventing deaths and overdoses.
Right. Right. No, that makes sense. And I think that's what's interesting. And I think this is a dichotomy that we've seen in being in the behavioral health space, especially in California, and I think in other states as well, where you have the treatment model that was historically more of a AA model, right, which was more of a social model, whether it's AA or other methodologies, but a social model and an abstinence-based model. And then, there's definitely benefits of that model, and there's a lot of success utilizing that model.
Sure.
But at the same time, because of the new the new drugs and the fentanyl and the new, just increased lethality of these drugs and the addictive nature of them, it really morphed into something where MAT became an absolute necessary standard, right? It was not something that the old methodologies could use. So now it's a combination of therapy and the social model, and you add MAT to that in order to kind of have the comprehensive treatment plan for a patient, right? Is that what you've seen since the increased utilization of MAT?
With the in the old days, basically our treatment was abstinence based only, and basically the treatment was 12 steps. 12 steps was the key treatment for all these patients, and of course, abstinence. But with the lethality of these new drugs, those by themselves will not work at this time. So we need new methods. We need new ammunition, new guns. So we need to mix the bullets with the missiles.
It's a war.
It's a war. It's a big war.
Against the war against drugs. And then also the treatment to help people who are in an addictive state. Dr. P, how can MAT reduce overdose? How can MAT reduce overdose deaths?
Okay, well, the first thing is you had to prevent people from relapsing.
Right.
Once they relapse, they overdose, and one of the problems when a patient relapses, they may go to a treatment center and they've been sober for about a month.
Okay.
And once they go out there, they think they can go use again.
Right.
But the problem is they have to get their body has to readjust to the new medications.
Right.
And what happens? They use too high of a dose.
Right.
And they actually overdose. But in the past, they were using the same dose in the past. But once they've been not using the medication, their body has to readjust, and at that point they're not ready to use those high doses. So
it's the timeline, and it's kind of the the steps towards recovery is step one is they go into detox and then they get residential treatment. Let's say detox is typically authorized by insurance companies for about 5 to 10 days. Let's say an average of 7 days,
Yeah.
right? That's utilizing medications to manage their withdrawals and kind of get into a state where they can actually get the residential treatment and get the tools that you need to and get enough time away from the substance, right?
So,
but then after the 30 days, like you said, if they just go back out there and now they've been 30 days sober, and then they think they could go back and use at the same rate or at the same level that they did a month or two ago, then that's where you have problems. And that's why we promote in our facilities, and you yourself as a physician, that ongoing aftercare, and whether it's outpatient treatment or whether it's an aftercare plan with their personal physician, is it doesn't stop. All of a sudden your problems don't go away after 30 days. You get off the drugs, you get into a state of mind where you now can achieve sustainable recovery, but there's still a lot of work to do, and that's part of the aftercare plan that we would put together, Ed.
Yeah. So the key thing is really how to prevent relapse out of the facility. After care. So there's different items that need to be worked on. Number one, they have to go to. It's good for them to go to AA meetings, try to keep their sobriety. Two is try to prevent cravings, and cravings are a big factor. So that's one thing. So Matt, the medications like Suboxone or buprenorphine, or methadone, or Vivitrol, all these type of medications will try to cut down the cravings and help with the prevention of relapse.
Right.
And that's the key thing is try to prevent all these cravings. So that's how Matt works. Buprenorphine satisfies the receptors, the opioid receptors, and it keeps them at bay. So.
Okay. No, that's actually a great segue into the next question, which is, we've talked about some of these medications used in MAT. We wanted to ask you, how does Suboxone actually work? Can you give us a little bit more of a detail?
Well, Suboxone, what it does, it binds to the mu opioid receptor. It's actually called the mu receptor. And once it binds to that, it satisfies the receptors, so there's no more cravings. But it's got a lot of good features to it. And Suboxone, even though it's an opioid, it's a synthetic opioid. But unlike the non-synthetic opioids or even other synthetic opioids, it has a long half-life. It binds to the receptor. So basically, number one is it doesn't come off the receptor that quickly. It'll stay there. The half-life is about 30 hours. So you can actually just take that once a day, and your body will be satisfied without any withdrawals. But once it binds to it, it satisfies the receptors, so there's no cravings, no withdrawals. Two is that the other important item to Suboxone, it has a very high affinity for the receptors, so it binds very strongly. And when let's say you take Suboxone or buprenorphine, and for some reason you go out and you start using some opioid again, whether it's fentanyl or anything else, the fentanyl is not strong enough to bind to the receptors, so you won't really. So normally you won't get as high, so you won't get that euphoric type of feeling. So you're not going to get as much an effect. So it's basically it's blocking the receptors, it's blocking all the other opioids from binding that. So that's very helpful. So
no, I think that's great, and I think there's obviously in our field we know all these terms and we know why people are addicted and why people do. But I think just the general public, the lay public, they might be thinking, well, why, if somebody almost died using a drug and then they went and got some treatment and they got better, why would they want to go use it again? Like, that doesn't make sense. It's not it's not logical. But can you explain a little bit of the why in people who have addiction, and especially with these types of drugs, because these are highly addictive drugs. They alter the state of the mind. What happens to the brain and to the person who, despite knowing the consequence of using something like fentanyl, for example, they still go back to it.
Well, these people do develop, two different types of addiction, more of a physical addiction and also a behavioral addiction.
Right.
And the physical addiction, we're actually, treating it with MAT or such as Suboxone. But the behavioral addiction, the behavioral and psychological addiction, that's a different problem, and that's based on their behavior, their other items that they have at home that are problematic. It could be stress at home, stress at work, relationship problems. But the other is the mental problems, like depression, bipolar, and some people just can have a hard time controlling their impulses.
Right.
So in treating addiction, we treat in different ways. We treat the physical addiction, we treat the behavioral addiction, we treat the mental state. So all those things come into play. Right. So there's a lot of items that are attached to addiction.
Right.
And it's kind of battling each item one at a time.
Really. Yeah. Yeah. I mean, that's what we've seen as well, is that, essentially, and everyone can label things differently, but, overall, the way we look at it is, addiction is under the umbrella of mental health. It's a, mental health disorder, and it's, you're utilizing the drugs in order to try to self-medicate because you're having difficulty, whether it's anxiety, depression, PTSD, trauma. I mean, there's just a myriad of things that people have gone throughout their life that has put them in a position where, they might want to seek that, that hit, or that, whether it's fentanyl or heroin or whatever it is for them. Right. And so, or it could be alcohol, it could be, everyone has their own drug of choice. What we've seen is from, 10 years ago to now, and I mean, you could go back 40 years, is that it used to be a little bit more straightforward. Like you had people with alcohol use disorder, just back in the day, they call them alcoholics. And there was a specific methodology for that. But now it's, I would say 9 out of 10, maybe 10 out of 10 patients have a co-occurring disorder, mental health disorder, an underlying disorder. So there's not just this simple just addiction. We're not just treating addiction. Now, sometimes addiction is primary and mental health is secondary. Sometimes it's mental health is primary and addiction is secondary. But we've seen that as becoming the norm, in that you're treating patients who, you have to treat both mental health and addiction. And so that's where, like we said, between the social model, between AA, between the therapy, between, we do EMDR, we do a lot of different modalities, and in conjunction with the medication and the, the nursing and the medication assisted treatment, you really have to be comprehensive. So that kind of leads me to, this progression in treatment. And, there's some people out there that might say, is someone truly sober if they are taking Suboxone? Earlier, you mentioned Suboxone is a synthetic opioid, right? And so to this example of we were talking about abstinence-based recovery, is somebody who's taking Suboxone truly sober? What are your thoughts on that, and whether that's even a way to think anymore?
Well, it's not really a way to think of it anymore. But you can say, well, physically, not truly sober, physically, because there's still the Suboxone is still the synthetic opioid. Your body, after taking it for a period of time, your body gets physically addicted to it, in a sense that you may have. If you stop it suddenly, you'll have some withdrawals. But the key thing is that it's a medication that it's not really making you high or euphoric. It's not affecting your lifestyle. You can go on with your lifestyle as you normally would. You can go to work. You can have a relationship. But you're not drug seeking. You're not looking for the next drug. So in the sense you're sober, that you're not using any type of illicit medication. But this is a medication, just like anything else, like treating hypertension.
Whether it's heart disease, cancer, whatever. It's something that's chronic.
It's a chronic. Yeah. It's basically it is a chronic disease.
Right.
There are some patients that will eventually get off it and not need it, and so the treatment has to be individualized.
Right.
If somebody is ready to get off it, then we try to help them out with that.
Right.
And
they have to have the motivation and intent, but at the same time, the part where they don't have control over is that craving and the relapse. And this is where the Suboxone or similar types of medications will assist them.
Yeah.
And most importantly, this isn't something they're getting off a dealer in the streets or ordering on the black market or whatever. This is something that their doctor or their treatment facility is working with them in conjunction to provide them with the comprehensive assistance. So if there's things that come up and they have questions, they can talk to the doctor, talk to the physicians, talk to the physician assistants, nurses, and have a whole team around them where they can manage it and control it, right?
Yeah. So the treatment for these patients has to be individualized,
right?
And because everybody's different. I mean, we get young patients that are abusing. We have older patients that are abusing, and we got people who are abusing it just socially, basically, or recreationally is the other word for it, or some are using it because of chronic pain.
Right.
And so as far as chronic pain, it's also a very good pain medication.
Right. So, and we've seen that with athletes. I mean, you've heard the stories. Yeah. He was one of the Angels players. There's just a long list of where, a lot of high school, athletes or college athletes, it's because of the pain management. Yeah. And ultimately that leads to addiction. So
you have to kind of look at each person individually, what, their age, young, old, whether they have pain or not, they have chronic pain. If they have chronic pain, it's actually a very good pain medication. So it's something that may have to be on it for a lifetime, unless their pain gets resolved by surgery or something, something else. Then they can get off the medication, not have to use it. But if you got chronic pain for a lifetime, then it's a lifetime medication that you need.
Right. And the irony, I mean, MAT is being used to treat addiction, but the irony is we mentioned fentanyl earlier.
Yeah.
And fentanyl, as you know, was originally produced and created for pain management for seniors. Yeah. Right. It was people who are towards end of life. And even now, I mean, you go to hospices, you go to senior care facilities or whatever methodology, that is, fentanyl patch, or they're using fentanyl to help people with, but then it became abused for people who are not at that state, right? And it became obviously what it is now. So, I mean, can you actually give us a little bit of a history, not too long, but just how it originated and then where it went from being something that was of benefit to a certain population to then becoming abused by the general population, and then now it's one of the most lethal things out there.
Well, what happened is when I first started practicing, people are using pain medications for their chronic pain conditions. It could be, acute. Could have started initially. These pain can started acutely. Maybe they had an injury, they needed orthopedic surgery, but they still the surgery didn't really completely heal their pain, and they still have chronic pain. Particularly the people with low back pain. That's a big problem. Even after surgery, they still have pain. And when in the old days, when I first started, we used to use Tylenol with codeine, things like that for pain control, and then that wasn't enough, so we had to go to other medications like oxycodone.
Right.
But then even stronger pain medications were developed by the pharmaceutical industry, fentanyl. So and that actually came in patches. So and it worked. And I have some patients that swear by it. That they started on it and they got taken off it. Now they really want to go back on it. They keep asking for the fentanyl patch.
Yeah.
But that's maybe about 30 years ago. I started noticing, hey, some of these patients are chewing their patches, and getting high on it. So then that started a big problem. But you got these patches you're supposed to put on your skin, and all of a sudden people are putting it in their mouths and chewing it. Man, that's ouch. Yeah. So.
Yeah. No, it's somebody who wants to get high will find ways.
Yeah, find a way
to get high. It's I saw a meme somewhere. It said, and it was kind of alluding to, if you really want to get something done, there's no excuses. But the meme was that, somebody could wake up broke, but if they really want to use drugs, they'll find a way to use drugs.
Yeah.
And so, I think that's what we've seen is, a lot of patients that are in, where their brain is, saturated with these drugs, and they're just actively seeking and craving drugs, is they'll find a way, whether it's chewing on a fentanyl patch or whether it's just, just all kinds of different ways that they access and use. But again, the focus here is that, and I think the beauty of what you mentioned earlier is, Suboxone specifically and the other MAT will assist them in not having those cravings.
Right.
And also to the extent that for whatever reason they do actually access the drug, because of the high level of the bond that it creates, the binding nature of the Suboxone, as an example, the actual drugs can't bind to those receptors, or even if they do, it doesn't give as much of a high. So then that reward mechanism of when they used and they got that euphoric high doesn't exist. So that in and of itself is somewhat of a deterrence from, okay, well, that's not giving me what I was looking for, which then promotes the sustained use of the Suboxone, for example.
Right.
And that's a question we'll get into a little bit later as far as, or do you have to take these for life or not? We'll get into that. But before we do, there's another question we have here that why is there still such a stigma against MAT inside the recovery community?
Well, I think that's more the older recovery community.
Okay.
That was founded basically on abstinence-based treatment, but I think that's going away, And there are some facilities that are still abstinent-based, and they really don't want any Suboxone like that. But I think for the majority of the facilities, they're finding out that it works, and it's very helpful, and so a lot of the facilities I work with are really into MAT at this point, and they're accepting it, and a lot of their clients are on it, and I think that's a changing thing. But in the old days, or even let's say Suboxone, there are some patients that they have chronic pain or actually abusing opioids, or they develop tolerance and they're using more than they should.
Right.
And but some feel that they don't want to get addicted to Suboxone either.
Right.
So that's a problem. But there are some people that still think, since because you get physically addicted to Suboxone, or because Suboxone has been the way Suboxone, when it first came out, it was basically came out for to use for addiction only. Okay, addiction only. So the problem is that somebody with chronic pain who's physically addicted doesn't want to get on Suboxone because of the fact that it's known as an addiction treatment medication,
Right.
And they don't want to be stigmatized as being addicted.
Right. And that's where the education. I mean, I think just to give my own history, 10 years ago when we opened our first facility, the normal state of mind, even within the residential treatment facilities, was more of the abstinence space and less MAT. And I would say over the last 5 years, it's really shifted to not only an acceptance of MAT, but really an acknowledgement that it is, the gold standard in relation to specific types of addictive disorders, right? And like you said, it doesn't apply to every single patient and it doesn't apply to every single scenario, but to not use it and to not have it within your system is essentially not within the times and not something that would be considered evidence-based treatment as of today. So, let's see. I think we're getting a little bit more into this, but we might have already answered. Do some treatment centers push abstinence because it's ideological rather than evidence-based? I mean, I think we talked about that. Yes, but now less, right? I think there's it's far and few between where you see that mentality, and now it's more of an acceptance and utilization. I mean, is that your general experience?
Yes, general. That's,
let's see. Here's a good one. I mean, they're all good questions, but I think I like the exploration of because you've mentioned so many important things, and I think people who are listening are going to think about how this applies to if there's somebody who's using Suboxone, for example, maybe they have questions. We want to answer those. If it's just people want to get educated on it, we want to have that resource. So, is long-term Suboxone treatment replacing one dependency with another?
I guess that it is replacing a dependency, okay, for sure. Long-term treatment, it's, you do get dependent on it, so you can say yes to that.
Right.
But you can say yes, but in a good sense.
Right.
In a good sense, not a bad way, you know. So it's protecting. It's very individualized. Some let's say some will need long-term treatment.
Right.
People with, as I mentioned before, with chronic pain will need pain management.
Right.
So that's replacing their pain medications.
Right.
So in a sense, it's helping their pain, and they're living a lifestyle, of not drug seeking. So that's good. So it's a good thing. So Suboxone is replacing treatment for chronic pain,
right.
But it's also replacing for other individuals who are just plain addicted to opioids.
Right.
For no medical reason other than addiction itself, then it's preventing them from relapsing.
Which is huge.
And as long as they're
essentially saving their life.
They're leading a healthy life, with family, with work,
right.
with housing, So if your life is all shattered, you're not going to have a home, a car.
Right.
You're going to be homeless. You're not going to have a family,
right.
and you're not going to have work either.
Right.
So Suboxone is actually helping with all those factors. It's keeping people is helping people lead a normal life.
Right. Right, and that leads to our next question, which I'll actually start with a little bit of our own anecdote, and then I'll get to you. But
sure.
Should MAT ever be lifelong, or should the goal always be tapering off? So, and I'll ask that again, but before we, kind of as a transition between these two questions, what I've noticed, and part of our training with our staff and how to work with our patients, is that it is highly individualized, and so it really depends on. You have to meet the patient where they're at. You have to give them the education and the resources and the tools. Ultimately, we can't force them to do anything, and it depends on what they're willing to do. But we also want to give them the right information. So, for example, somebody might be coming into treatment. It's their first time in treatment, and they don't know whether they are going to be in and out for a long time, and if this is going to become a chronic, it's something that's affecting their life now, and they want help, right?
Right.
And so there might be a way to, we would give them certain things while they're here to help them with, including MAT. But for that patient, it might be more of a shorter term. And of course, it would be aftercare recommendations. I'll allude to you for more specifics. But then you might have somebody that, over the last 3 to 4 years, they've been to 20 plus, 30 plus treatment episodes, and they've been in and out, and they just haven't, they've gotten sober, and then 30 days, 60 days, 90 days later, 6 months later, they've relapsed. And so this chronic, I think that's, if somebody's a chronic relapser, then all of a sudden now it's, do you want to be a chronic relapser and do this for the rest of your life? Or would you rather take Suboxone and, you could be a high functioning person in society, have a family, and not be impaired during your day-to-day activities, but at the same time, prevent the relapses. So I'll ask the question again, but I think that's been our experience, is that, we don't shove anything down anyone's throat. We want to give them the education and the resources to be successful. Again, we take a look at their history, their treatment history, and their biopsychosocial, and then with the, with the medical team, they'll assess and give them the tools, whether that's short-term, whether it's long-term, whether it's something that they need to, taper off, and then the dosage, that's all determined based on their specific situation. So having said all that, the question is, should MAT ever be lifelong, or should the goal always be tapering off?
I would say both. It just depends on the individual.
Right.
And, what, I guess you have to kind of get an idea what their success rate is. And also what they want to do, so you have to give the patient a choice, so if they want to try just a short term, fine, that's what they want. That's what we'll try to help them with that. But we have to try to guide them through and try to help them, if it's, let's say if somebody has psychiatric issues, you want to make sure, that once they're off the Suboxone, they're tapered off, but then their psychiatric issues continue to be treated. Okay, so that's if somebody has, let's say, an older person with chronic pain, whose pain's not getting better, then we have to make a decision whether they need to be tapered off or not. If we do taper them off, then they're going to have back their chronic pain. And so we have to decide, okay, what do we do with it? How are we going to treat their chronic pain?
Right.
And what's the best choice for them? So because we don't want them to start abusing again,
right,
and we don't want to start using opioids again. So, but then we run into a problem. What are the choices? So we have to discuss with that individual. Okay, we'll take you off buprenorphine, which we're using to treat your chronic pain at this point. So let's say if your chronic pain still continues, what do you want to do? Do you want to go do some surgery? Try to remove that problem surgically. But if that's not available, or then you start thinking, okay, you're gonna have pain again. What are you gonna use? You're gonna take some Tylenol. You're gonna take some ibuprofen. But the problem is, take too much Tylenol, you're gonna injure your liver. Take too much ibuprofen, you're gonna injure your stomach. You're gonna have gastritis, peptic ulcer disease. Also, you're gonna injure your kidneys because non-steroidal anti-inflammatories injure the kidneys for long-term use, high doses. So that's even more of a problem. But then the buprenorphine, it's a lot safer medication for the liver and the kidneys. So it's not. So so you have to kind of put those issues. It depends
on the reason that they need it, and then customize it accordingly.
And try to devise the treatment. But if they're ready, they're gun ho. I'm not gonna use again.
Right.
Yeah, let's taper you off. And sometimes tapering off is not easy either. So then you have some withdrawals.
That could take some time.
Yeah.
And then
but
it's good to do that while they're in some extended recovery.
Well, in recovery they're safer. Yeah.
Right. Would you say, because one of the things we do is therapy, right? We include individual therapy, group therapy, marriage and family therapy, and different modalities of therapy, whether it's CBT, DBT, we have EMDR. And, one question we have here is there a risk that MAT is sometimes used as a shortcut instead of providing real therapy?
No, it's not really a shortcut. It keeps them in progress. It keeps them in therapy, actually.
Right.
Without it, they'd be out of therapy. They'd be out on the streets using.
Right.
So it's not really considered as a shortcut. It's an assistance to keep them in therapy, really. So
Right. It's essentially, it goes hand in hand.
yeah, it's a combination. So
Got it.
yeah.
Got it. Okay. Should every opioid use client or patient automatically be offered MAT? Or would that be kind of an overprescription of it in that scenario?
They should be offered. I mean, they should have a choice
Right.
whether they want MAT or not. So it's
So-
I think
and
it's a
that's
must.
one
Yeah, it's
I was going to say
yeah.
that's one thing is the education.
You have
right?
to
So
educate them.
you
Yeah.
look at their history, assess them, do the psychological assessment, do the physical assessment, and then so actually, you know what? I mean, you're the physician. So what are the when somebody comes in, let's do it this way. Someone comes into treatment, and as a medical director, your medical team will be the first. You'll see them within the first 24 hours, right?
Right.
And so can you kind of, maybe there's a family or someone watching at home that would like to learn more about what that looks like when their kids or if they want to go to treatment, what does that first 24, 48 hours looks like as far as getting assessed and being put on, a path from the medical
Well,
team?
for the medical, so we have to find everything about that patient.
Right.
We have to take a good history. We take a history of what medications they're using, or first which addictive medications they're using, whether it's alcohol, benzodiazepines, Xanax, things like that, or opioids, things like that. Try to define the problem, and then try to focus on that addicted sense.
Right.
But also, not only that, take a psychiatric history as well, see whether they have any psychiatric issues like depression, anxiety, bipolar,
Right.
schizophrenia, those type of things. Because there's a lot of people that are dual diagnosis,
Right.
and that by dual diagnosis they have a substance use disorder plus psychiatric issues. So we have to make sure that the psychiatric issues are being treated as well.
Right.
And we also take a history of, medical history like allergies, things like that, any major surgeries, they have chronic pain, things like that. But we look at their medications, and we take a look at medications that they're on, if they're interacting with the medications that we're going to be using, things like that, and of course do a complete physical examination on them, and then from there kind of devise a plan. If they're coming into a treatment center, then we devise a detox plan, which medication we use to help them detox off the medications.
Right.
We offer them the counseling, so the group therapy,
Right.
things like that. But then and also some comfort medications. Some when they're detoxing, they have trouble sleeping, and sleep is always a big issue. So we try to give them certain medications for sleep, insomnia, things like that. And then, of course, they do have withdrawal symptoms when they're detoxing, so we help them out with withdrawals, like symptoms like nausea, vomiting. So we give them medications for that. We use a little bit of Zofran and all that. So we try to keep them as comfortable as possible.
Right.
But those are the things. And but not only that, that's the first part of it. Then the next part is just follow them in the treatment center on a daily basis. Let's see how they're progressing, see what new problems they develop, things like that. Sometimes we do issue We do some laboratories to look at their electrolytes, their liver function tests, kidney renal tests. Sometimes we do an EKG, things like that, because some of these medications will have some side effects, some certain problems with certain cardiac diseases.
Right.
But it's an overall look. I guess it's like taking your car for a complete tune-up and overhaul at the same time.
Right. That's one thing. The irony of what you just said is, we have clients or patients who've come to us, obviously for addiction treatment or for mental health treatment, and through that process, they discover that they have some other health issues as well that they were not aware of before. So then now they can address that as well.
Yeah.
So we really do such a comprehensive, both through the assessments and also through labs and through testing, to really show the patient and their family, a comprehensive look at their health and their mind, and then the tools to address that. And so I think that's actually one of the real benefits of the wellness component of our treatment facilities is, yes, it's evidence-based treatment, but it's also a wellness program where you can come and, learn more about yourself and get the tools you need in the aftercare where you can, get better, for everything. You can be able to drive, all the way from here to Washington, D.C. with that car.
Yeah, and one thing, and these patients, some of these patients that come in also have certain risk factors.
Okay.
And risk factors, if let's say they use IV drugs or things like that, intravenous drugs, then they have a risk factor for the hepatitis C, things like that. So we kind of, on the drug test, we screen for that, or HIV, screen for HIV. So, or some STDs as well. So, but there's all kinds of different things going on, but yes, they're using drugs, but where have you been and what have you been doing?
Right. Well, where have you been and where are you planning to go? I think that's also as important as we have and we can skip that next question, but we have a lot of times, and I think this is something that you've seen in addition to your addiction practice, your family medicine practice, is people are coming from a place where there's dysfunction, right? And that's maybe the younger clients that are living at home. And, it was like, why is my son or my daughter addicted? And, the guy could be a doctor, he could be a lawyer, he could be some businessman. And he thinks, we've got everything figured out and we just need to, here's the 3 steps we need to take to solve this problem. And they're just so used to, because there's a lot of people who are used to solving problems in their business and their other avenues. But then when they have mental health or addiction in the family, they're completely lost because that same mechanism that they use in business, which is, hey, we'll reward you if you don't use, for example. Right? If, Johnny, if you don't use, we'll give you a car, we'll send you on this trip, or that doesn't necessarily work, right? And so I'd like you to just, based on your experience, both as raising a family and also treating a lot of families, what are people doing wrong, essentially, in these family settings where it's counterintuitive that it might make sense outside of the mental health and addiction world, but inside this world, it's actually doing more damage than good? And what are some tools that you could give to family members at home that are struggling with this disease inside their house? Obviously, they could go to treatment, but just within their own environment, how can they address these issues without making it worse?
Well, it's difficult to have somebody that has an addiction in your family, and it's difficult for the members of that family to be involved in that, and so they really have to get their loved one to a specialized place for treatment, but just trying to keep them in the home is not going to work,
Okay.
Or there are some people that, we tried, we had you at the house. Well, let's get an apartment for you.
Right.
And I've seen that situation happen where the family gets that teenager or one that's just turned 18 or something like that, their own apartment.
Right.
Now they're on their own,
Right.
and that plus drugs being out there just
Bad
like
recipe.
that's a bad recipe. You just cannot do that. So you have to get them to a specialized treatment.
Right.
You better I think you'd be better off kicking them out of the house, but that's so hard to do if
Right.
you're the
Right.
parent.
That's the dichotomy.
yeah.
I mean, that's I'll allude. I mean, I guess current events are important. As a because people are hearing it and listening to it. But we had the Oscars were the other night, and you had Rob Reiner and his wife who were murdered by their son allegedly. I mean, it's an ongoing case and investigation. But just using that kind of example where you had a family who had resources, significant resources, that their son had been in treatment, but at that time he didn't want to be in treatment. Perhaps he was on medications. Perhaps he didn't want to take his medications. He was living in their house, and so now there's risk to them. Versus if he lived on his own, or versus in that specific case, maybe he should have been at a certain facility. But I think just as a general, there's a lot of fear. I think if you're a parent, you're scared to kick him out. Now you're scared to keep him around. How do you navigate that?
Well, I think that at that point, when you have something like that, you really, you have to find out what the problem is, and you probably need to send them to a specialist.
Right.
Just at least a visit, to see either addiction medicine physician or a psychiatrist, because the underlying problem may be more psychiatric than anything else, and that person may do a lot better on a 5150. That's when they're
right. Suicidal or
they're
going to harm somebody or themselves.
So it's best to do a 5150 and try to get them some
right. And it's just such a challenging. We've had situations where somebody might have our team is actually, while they were in our facilities, called for a 5150, and then those people come out, and sometimes it works because the patient will exhibit those severe symptoms in their presence. And sometimes the patient will they're very manipulative in that state of mind, the patient is. So, they'll all of a sudden, oh no, I'm fine. In that moment, right? And then they leave, and then so then we'll have to refer them to a higher level of
they
care.
don't take the medication.
So it's just very tricky. And I think, to the extent that everything you said is right, but we've had clients who they just refuse, or they leave. They leave against what we call clinical or medical advice, right?
Or against medical advice.
Right. Or in a situation where they might be not even at a facility, they might be living at home or in some sober living environment, where they refuse to take their medication, where they're, not adhering to the protocol that the physician or the treatment facility has set in place. That's one of those where you kind of throw your hands up, because what do? You kick them out because they're not adhering to it? Do you try to work with them? And obviously we do whatever we have to do based on our licensing standards and things of that nature. But I could see both in a facility and also more importantly, just somebody living at home where the family is really being as supportive as they can, but they're now being resistant and not taking their medications. I mean, you have so many kind of pop culture examples of, whether it's, I don't know, Kanye West went through, high functioning artist to just kind of off the wall. And now, and it's a lot of it is tied to whether they're taking their medication or not. You had the situation with the Rob Reiner son. You have a lot of these in pop culture, which grabs the population's attention. But for every one or two you hear in the news, there's lots of families and thousands, if not, hundreds of thousands of people dealing with this at home, maybe millions of people dealing with this at home. So I guess the question is, if you have somebody who you've done all the right things, send them to the physicians, you send them to the experts. There are medications, there's things that are in place, but they're not adhering to that. What are the potential options in those situations? Or what do you do in those situations?
Well, a lot of it just depends on the behavior,
Okay.
So they're acting very irrational, erratic, hallucinating, got to take him. You have to get him to the ER.
Right.
You may have to call 911 to get that situation, because sometimes these episodes or people don't want to, are going to resist everything you do. So you may have to get
That's
some
a full
help.
court press session. I mean, you got to intervene to the best of your ability. And I think the timing is important because, in our facilities, we act very quickly, right? We don't just allow it to happen for a prolonged period of time. However, at home, as a parent, you try to give people the benefit of the doubt, and he's not feeling good today, and he'll be better tomorrow. And I think when it comes to mental health, especially people with more severe cases, the advice to people at home would be, it's not something that you can just wait till tomorrow, or let's see, let him sleep it off or something like that, right? Know what happens 3 a.m. When somebody wakes up and they're in the middle of an episode, and now you don't have the resources around you. So I think that would be just one tool or one advice, is that, you got to take every episode and every outburst seriously, and you have to escalate it. And to the extent that they're not adhering to the medication, you need to essentially internally refer them to some higher level of care, and remove yourself from the problem to the best you can, because you can't solve the problem. You don't have the resources or tools as a parent to solve that, even if you're a physician yourself. I mean, I think a lot of people, even in the field, if it comes to your own kids, you need to have somebody else, because you're not going to be effective in that scenario, right?
Yeah.
So
you're not going to be objective. You're going to be very subjective.
Right. Right. And we've seen people that are in recovery who have family members that need help. We've seen people who are therapists who need family members who need help. And we've seen doctors who have family members. So it's not, there's no magic science. People think out there that, there's some magic science and there's some expertise where, no, this is mental health is something that permeates society in a way where it can touch anybody. It doesn't discriminate. You could be rich or poor. You could be, any race. It's really, it doesn't discriminate as far as who it impacts. And so that's why it's such a lethal and chronic situation, and that's why it's such an epidemic. But as you said, I think MAT and the new resources and tools that we're finding are more effective in treating. And so, we mentioned earlier, I do have a question for you. So, one thing that you've mentioned, Suboxone, you've mentioned buprenorphine, you've mentioned Vivitrol, and a lot of these are tools that our facilities utilize and we offer patients, whether they're in our facility or as an aftercare tool. But we've, as a facility, somewhat stayed away from methadone as a treatment modality, and we know that there are actual methadone clinics. So it's something that's kind of its own specialty. It's a form of MAT, but I would consider it more of an extreme form, and then not, in the same category as the ones we've mentioned before that are what we utilize. I'd like you to explain a little bit what methadone is and why that is something that we consider more addictive. So we don't necessarily prescribe that in our facilities, but there are certain clinics that for people who do really need that, where it could be beneficial.
Well, methadone is part of the MAT treatment,
right?
MAT, and the only difference is that methadone is a full, let's say it's a full agonist as far as binding to the receptor, as compared to buprenorphine, which is a partial agonist.
Right.
And the problem with a full agonist, it can behave like the regular opioids in a sense.
Right.
It may cause some euphoria, a little bit of euphoria, not as much as the regular ones. But the problem is it is a little bit more dangerous, because as a full agonist, if you take too much, you can overdose on it, and you can die from it. So, it'll impair your ability to breathe, so lower your respirations.
Right.
So that's why it's taken more serious. So as opposed to the buprenorphine or Suboxone, the Suboxone is a partial it reaches a point that taking too much, you're not really going to overdose on it at that point. It's a
So
safer.
we recommend that
it's a
more
safer. It's a safer medication to take. Because it has a limit that it reaches, and after that, you're not. It's not going to impair your breathing or anything like that as much. But as far as the methadone, that if you take too much, it has to be monitored. As far as when given to you, it has to be gradually dosed up. It's not something that you take a large dose.
Right.
You start taking large doses because what's happened is with the methadone, when you start taking it, it may take about 3 days, maybe 3 to 5 days to reach a steady state level. So if you're taking a high dose, if you start at too high of a dose, 5 days from now you're not going to be breathing or even alive. If you so that's
a lot more dangerous. That's why we don't really do it at our facilities. But there are special clinics that do it. And
also it takes longer to to build up on the methadone to get started on it. In the facilities we only got
so much time.
So much time for detox, so much time. The insurance just will not cover. For the methadone clinics, they gradually they see the patient on a daily basis, sometimes daily to weekly, and they give you a gradual dose because knowing that if you give you too much, it can be dangerous. The other thing is the methadone is given in methadone clinics, which are more governmental type of clinics, but they're not. Methadone is not available in the private office
because of how dangerous
for addiction.
Right.
But methadone is available in pain management because it's a pain management drug as well. But so physicians can give it for pain control, but it's not medication that's given by regular physicians for addiction.
What have you seen as somebody who? Because most of our clients with the MATs that we talked about, Suboxone and Vivitrol, buprenorphine, and other ones you've mentioned, that's the model that we use, the MAT model we use. But why would somebody be a candidate for a methadone when what kind of, because of how in general we don't like it because of how dangerous it is, but we
methadone,
don't even do it. But for the places that do it,
let's put it this way: methadone came way before buprenorphine. Okay, So that was the MAT in the old days. That's and then to treat substance abuse, then these methadone clinics were started but controlled by government. So so that was the first line of treatment at that point in MAT history. But then buprenorphine came along, which is a lot safer medication, so that
so there's been all these advances essentially.
So that way regular physicians could qualify, to treat with buprenorphine, but later on that even got expanded more to even
so
more
really
physicians.
Increased access to care as well, so more people can get the help they need.
So basically, you can say buprenorphine is a safer medication to give than.
Got it. Okay. No, that's. I think that's. I mean, people are curious about these things. So, now, have you noticed people relapsing even if they're taking Suboxone or methadone or other medications? And if so, why would they relapse in that scenario?
Well, I've seen people relapse. Really, with Suboxone or buprenorphine, it's the relapse rate is a lot lower.
Okay.
And probably the reason is that if somebody accidentally uses or even if they get a brief craving, they take something that they're not going to get that high because the buprenorphine is blocking that receptor for those other opioids.
Right.
Okay, so they don't get that high. So that kind of helps.
Right.
Quite
Eventually,
a bit. Yeah. So they don't get the high that they normally would. But on methadone, I've seen people that still go out and they're abuse because the fentanyl is pretty potent. So it kind of So the fentanyl and let's say the fentanyl and the methadone both compete for the same receptors, and the fentanyl can outdo the methadone.
Right.
And I've seen patients that have been on high doses of methadone and fentanyl, they still get high on with the fentanyl. But with the buprenorphine, it's harder to kick off the receptor, so they don't get as high.
Well, that's interesting.
Yeah,
So it's a much more advanced medication and much safer. So
much safer, more advanced, and the good thing, both have a good long half-life, which kind of helps.
Right.
But other than that, that's
so it's both good as a short-term, while they're in treatment, and also something that if they choose to taper off, we have the tools to help them do that. If they want to stay on it, it is something that they can be high functioning versus if they, with Suboxone or buprenorphine versus methadone, which is you're essentially impaired while you're on it. So I've heard a lot of anecdotes of people. It's just like, it was worse than being on drugs type of thing.
The thing about methadone, once you're methadone, usually, let's say you're a substance abuser, you're on methadone, you really got to go to methadone clinics when you first start on a daily basis. I mean, a daily basis, just daily to weekly.
It's like your whole life is altered.
The Suboxone is, I can see a patient that has an opioid use disorder. With the Suboxone, I can give them a week's supply and detox them within a week. In the office. Okay.
Right.
And then on a monthly basis, just following the monthly basis, give them a month prescription for a month supply of Suboxone. And so you see them on a monthly basis. But with methadone, you got to keep close monitoring. So
it's its own thing, and if anyone's doing that,
it's a lot harder.
They have to.
I mean, if you're a person that's has a business, is working, you got to get to work. Suboxone's the way to go. But methadone, you're going to be at the methadone clinic rather than at work all the time.
That's its own. It's like its own job. All right. Well, thank you for sharing that. I think that's important information. Can MAT sometimes delay true psychological recovery from addiction?
What's this question?
I think we've gone over some. I mean, can MAT sometimes delay true psychological recovery from addiction? I think we've addressed it. Right?
No, it's not. It won't delay. It'll just it'll be helpful. It
helps you stay in treatment essentially to get the recovery that you need, and then to the extent that it's part of your aftercare, you can still see a therapist. You can still go to an outpatient program. And it could just be used in conjunction.
It keeps a person in the game right there.
Right. Now, based on the different medication MATs you've described, are some of them, based on how much is used, could make the patient emotionally numb or feel kind of like they can't feel certain things? Or is it, can you explain a little bit about that? So a lot of patients are like, should I take this? Should I not take this? How long should I take this?
Well, number one is it's going to numb the cravings, for one thing, the emotional cravings. Psychological, it may numb you, it may make you slightly emotionally numb, as far as anxiety and things like that. So just a slight numbness.
Still be high functioning.
High functioning.
Go to school, go to work. Take care of your family.
Think rationally.
Think rationally. Yeah. So, that's an interesting question. So, I wonder if you've heard about it. So obviously, through our facilities or somebody going through you prescribe the Suboxone. It's coming from a licensed facility, licensed physicians. But apparently there's some people who buy Suboxone illegally. And the question is, why do some people buy Suboxone illegally instead of going through a doctor? Have you even heard of that? Or is that, why would somebody
that happens because, it's sometimes it's, street medicine, it's easier to get it off the street, number one. For some people, they're already on the street and all that, and then there are a lot of contacts. They have people that have Suboxone. It's just easier just to shell out. Two is, sometimes a stigma. You don't want to go to your physician and then have that stigma of being a drug addict because you're on Suboxone and all that. Then you go to your physician. Then they go to your insurance and all that. You don't want your insurance to know it. Things like that, but a lot of it is just
a lot of it.
Stigma.
That's just completely. To anyone.
or
you could get it through the doctor.
But I think a lot of it is that there's people out there that are on street drugs,
right,
and they run out of their heroin, and they're withdrawing. They need a quick fix. So
their dealer has
Suboxone.
Their dealer has an illegal supply of Suboxone to help them.
That's it. Yeah,
and then give them the drugs again.
Yeah, so it's
stay away from your
quick.
dealer.
It's quicker. It's easier, and they get it on the spot right there. Right. So.
But you could just as easily go to your physician and get it, and based on what you've described, it's something that if they're the right fit, a physician can prescribe that in their private practice, or if they're in a facility, you could prescribe that while they're in the facility. So it's very easy to access, and the stigma should really be reduced because the access to care and the evidence-based nature of it is really a treatment modality. It's just like if you were taking heart medication or you were sick and you're taking medication for that. This is medication for your addiction, and highly recommended. Dr. P, would you say what is the impact of MAT on the fentanyl crisis itself?
It's blunting it. Okay, so it's so I think that it's helping. I think the combination of everything, as far as MAT, as far as therapy, group therapy, psychiatric, all that is helping. You need all the weapons, all the ammunition you can get to fight it. But as far as MAT itself, it's helping quite a bit, and it's blunting it. So now we're seeing less overdose deaths.
Right.
In the past 2 years, the death rates have gone down now in the entire United States. But let's see. But the death rate from overdose has been increasing from 2015 all the way to 2022.
Right.
23, but in 24, 25, it's starting to.
I think that's correlated with the push of MAT. I mean, I can tell you just from a licensed facility, the Department of Healthcare Services really started promoting and pushing and requiring our facilities over the last few years versus 10 years ago it wasn't a requirement. So I think in combination with the resources from the state and also the education and the tools to provide that, there's definitely been a positive impact that we've seen. Now, would you say because of how important these medications, and we're almost done, but because of how important these medications are, for example, Suboxone, should Suboxone be easier to access without prescriptions, or do you still believe that a prescription is necessary?
I still think prescription is necessary. Okay. It's still it's a controlled substance, and if not used properly, people can get in trouble.
Right.
Yeah.
We've got a couple of questions left. I know you're a very busy guy. Got to get back to your clients.
Let's see.
So
1 more minute left.
We got 1 more minute.
Before I start.
Is addiction primarily a brain disease or a behavioral issue?
It's both. You can't say one or the other. So
right.
It's both brain and the brain is more. There's a lot of chemical processes going on, electrical, chemical processes going on in the brain.
Right.
And drugs have altered that chemical process, and the circuits are switched around, changed. So that's the brain process.
Got it.
But the other problem is more of a psychological, social issue as well. So there's
it's both. It's next question. Next question. Is that the last question or? This is the last one. I think we can end with this. Is a little bit more rhetorical, okay? So we've talked about everything that's very specific. But if you, Dr. Pedinari, could redesign the addiction treatment system in the United States, what would you change first?
Well, let's see. I think it's all these years it's been redesigning all the time.
Right.
It's been so there's. I think the way to go is how to. I guess the one big problem right now is that probably about 1 out of 5 people that need treatment have only been treated, but there's the 4 out of 5 that still need. So we need to spread the word more. It could be a matter of just not knowing the availability of treatment to the or more financial or insurance.
Right.
So I think we had to probably get more funding over to the system
Right.
in treating addiction. I think that'd be the key thing. But how to do it should be done in a rational manner,
Right.
in a way that's cost effective. So
Right. And I think just to kind of finish on that thought is, access to care and people actually wanting the care and taking the steps to get the care is incredibly important. And then to stay within the care, right? I think a lot of people come in and then they want to leave because, they don't want to be in a facility or because there's the stigma. And it's just, at the end of the day, the clients and the patients that are successful and the families that are successful are the ones that essentially stay out of their own way. And they say, look, I've tried everything, or I've just, this is something that I can't control. And I'm going to listen to the doctor. I'm going to listen to the facility. I'm going to go to therapy, and I'm going to do this, in a sustainable way and make that part of my life. And now, I can be high functioning. I could go back to school. I could go back to my job. I can take care of my family. But this still needs to be part of it. And I think something that's good about our programs is that we have both in-person programs and we have virtual telehealth programs for the aftercare. So if it is somebody who comes in, they need to just detox, then we could do that. If they need to come for a full, residential treatment and really get that enough time away from the drug, we can help them. But then they can go back to work, they can go back to school and still be part of the program through our virtual program. And so, we like to provide people as many tools as they can in order to kind of eliminate obstacles. And then they can have access to a care team where they can feel comfortable asking these questions and getting the support that they need. And we also provide support to the family members at home so they can make the changes necessary at home to be conducive to the treatment that the patient's getting out of.
I think the importance of a treatment center is not just to treat the patient there at the center, but I think it's also to take a look at the aftercare that you're doing and try to keep in touch with that patient, for the future on.
Right, exactly.
So you can make sure that patient is still abstinent.
Right. Yeah. No, I appreciate your time, Dr. Penner. I know you're very busy.
Sure.
Thank you for providing all these resources for people out there and answering these questions, and also for our staff to learn from your training and from your expertise. It's been a great resource for our staff and for our facilities throughout the years as well.
Thank you. Thank you.
Thank you, everyone.